Morning, everyone. I want to thank GC for inviting me to speak here today, and also congratulations on 100 years. That's outstanding. That's a spectacular company. You heard a little bit about me. I'm a graduate of NYU. I received my accreditation with the AECD in 2000, but part of my education that makes me the dentist I am today, believe it or not, is the high school that I went to. This is Brooklyn Technical High School, and we are having our 100th anniversary. I have a fellow graduate out here next year, coincidentally. Yeah. And just a little bit about this to tell you what my perspective is as a clinician and an engineer. First 2 years of the school, and this is a public school, by the way, as in free education, okay? First 2 years, a lot of material science, basic engineering, machine shop, woodworking, foundry, things like this. Your last 2 years, you select a discipline. So for me, it was college level chemistry. My dad was an aeronautical engineer. Brother was architecture. So you pick what you want. So my point is that I'm looking at things, of course, like yourselves as a clinician, but also I'm looking at the engineering, the chemistry side, as well as the compressive strength and the specifications. So it's a little different. In our 100-year existence almost, we actually have 2 Nobel laureates, and I'm not one of them. We also have the founder of Barnes & Noble, Len Riggio, a NASA astronaut, a Olympic medalist, and Harry Chapin, if you know who that is, a singer-songwriter, was in there. It was from Brooklyn, too, as a matter of fact. I always feel like an underachiever when I go through this part. About 32 years ago, I moved to Bucks County, Pennsylvania, where I love to bike along the Delaware River. And I invite you, come out and see me sometime. But you got a bike with me. Just want to talk about the extreme makeover phenomenon, which really changed the way we practice, especially me graduating in 1985. So we entered a whole new age of dentistry. Everything was kind of obliterated. Doing amalgams, plugging amalgams, that wasn't happening anymore. So I just want to think about this for those that are my age and even younger. What we've gone through since maybe 2003 approximately. Look at all the headlines. We got put up to the level of plastic surgery when you think about it for what we do. And it's something that I could have never imagined that would happen. Look at how things have changed, and we've been to it. People Magazine, and of course, the Academy's Bill Dorfman, Dr. Bill, bringing this kind of consult to people's living rooms with the extreme makeover phenomenon. And what I want to say about this is this has gone from phenomenon to mainstream. So for us, patients come to the participants of our courses practices. They know this stuff works. They want them to be able to do it. So that's where we come in, giving them those skills. So it's very important to understand that evolution. I was part of a transformation show on the Comcast network, and we did 7 shows together with host Lynn Doyle. And I worked with a plastic surgeon, a hair specialist, and of course, I took care of the smiles. Here's a clip.
Great dentist as well. Dr. Maris, good to have you back with us.
Thanks so much.
You heard people say earlier in the show, Zane and David, that her smile is impressing them.
I was a little younger back then. First participant came in, and this is how she presented.
Getting the teeth done to me is just as important as the cosmetic surgery was. It's something that is part of how I present myself to other people, and I've always been self-conscious of my teeth.
Notice the focus on the smile, even in the shadow of having $50,000 worth of plastic surgery done. So understand the importance that we have. We know that, but this is something that we want to impart in our courses to our participants, that even if you're having a tough day, pat yourself on the back, because at the end of the day, dentistry is a profession where we do good. We generate a lot of goodwill, and we change people's lives. Here's a smile before and after. 10 feldspathic porcelain veneers in this case. And then her glamour picture. How would she look without that smile? Right? It's part of the package. So important.
Seeing her, both of you, is the most, the thing that really impresses you most about her transformed look. What hits you from the moment you see her?
Her smile.
And that's from the hairdresser. Think about that. Another participant came through before and after here. Also, in this case, I did 10 feldspathic porcelain veneers.
They look really good. Thank you.
You're very welcome. You're welcome.
Thank you. Really so good they look.
You can see the impact that we have. So understand, you transform a smile, you transform a life. And that's something I impart to the participants in our courses too, very important. One last thing, and I want to get to the nature of the adhesives and cements, is that I lived through, just the way luck would have it, the evolution of the dental practice. When you think about when I graduated school, being able to restore a class 4 with 2 shades. And just keep in mind, I grew up with that box of 12 bottles of Kerr, opaquer tints that we had to go through to get a result like this. And now 2 shades are able to do it. Hard to believe. Same scenario, 2 shades. Also, injecting composite, like with Genial Universal Injectable, for these little micro restorations, these little micro class 4s. Who would think that's possible years ago? Okay, treating white spots like this, hypercalcification, that can't be treated with resin infiltration, of course. Got to go deep with these. Class 5s with injectable composite. Okay, putting injectable composite under heavy load in occlusal applications. Who would think that's even possible? Okay, all ceramic resin retained bridges. Think about them, all the Maryland bridges you cemented in over the years. Incredible. Also, monolithic zirconia inlay bridges. Who would think this is possible? Zirconia crowns, which full contour, I can roll over with my car and they don't break. You don't have to worry about marginal ridge fractures like the days of PFMs. Preparation is a breeze, kind to the tissue, hard to believe. Okay, 300 bridges made of full contour zirconia. Again, unthinkable. Also using Lisi press, monolithic lithium disilicate, giving you a great result, an aesthetic result on these 2 laterals. Another case like this with 6 monolithic veneers. Why monolithic? No chipping on the incisal edge, right? You don't have to worry about it on the cutback scenario too. So less maintenance for me in the future. Implant results like this, where you can actually manage soft tissue and of course the veneer scenario or crown scenario that looks like enamel and looks authentic. Hard to imagine that this could be done. I couldn't even think about that graduating in 85. So for me, it's mind-boggling every time I do it. I do it not as a matter of fact, I do it with pleasure, but it still stuns me when I insert cases like this, that I could get that result. And you think about our predecessors, how they struggled to bring us to this level. Oh, it's tremendous. Dentists doing Botox, gummy smile treatment. Who would think that this would happen? Smokers' lines like this. Patients come in for my recalls and I take care of their Botox for them too. Okay, worry lines like this. Liquid blepharoplasties, crow's feet. Hard to imagine that dentists would do this. It's still incredible. Here, like kind of that little bunny line, right? The nasalis muscle, corrugator muscles. Dentists doing Juvederm, the advantage of injecting so patients don't feel you threading the syringe, okay? We have tremendous advantage with that. Who would think that's even possible? And yet here, it's commonplace for us. So what I want to say, in summing this whole situation up, is that today, everything works. We have products that are outstanding, but the question becomes now, which works the best? And that's why I like to use GC products. And I'm going to talk about the ones that I use. Just want to do a quick history and breakthroughs on adhesive to show you how far we've come. If you look at, even in the 40s, just treating enamel with acrylic, you got some bond strength, not much to speak of, okay? And then Bonacor in 55, published in 56, started acid etching. So we got increased strength, okay? The creation of a hybrid layer, in these 2nd generation restorations. Then getting into the Japanese and Fusayama, also managing the concept of etching dentin, which was a horrifying thought for us in America, that it would be instant endo. And that turned out not to be true, okay? So look how far we've come on that side. And that brings us to the 3rd generation of adhesives. John Kanka then brought that whole concept of leaving things a little wet and you double the bond strength, okay? In the 90s, another 4th generation scenario. And that, of course, puts us to what's called the gold standard, which was Optibond FL, okay? So that's a 4th generation 2-bottle system, of course. Put everything in 1 bottle, that's the 5th generation, okay? Getting into 6 generations too, you're getting into self-etch as we go. And concern is not opening the dentin tubules with the acid, less sensitivity. So that was the driving force behind that. And you see the products that are available like this. 7th generation, the derivation of that in 1 bottle and usually water-based. And where we are today, 8th generations with the use of MDP, which keep in mind goes back to Panavia. Remember how well that worked, right? So that's the basis of your 8th generation, where you really have everything together and getting a tremendous result with that. And if you look just briefly, look at how far we've come. 2 megapascals of bond strength to 30 plus, even 40 with G2 bond, which is incredible when you think about it. That's some evolution over the years. We've got to be proud about that in our profession, material science. So let's start off talking about G Premio bond, which I've been using for several years now. And this is a great product because it's convenient. Everything is put together as one, and it gives you full mode, whatever your preference is, total etch, selective, self, and dual cure compatibility with cements. It opens up all the doors, hence the name universal. So all modes are there available. But I must say the most effective and the most important of those modes is the self-etch, selective etch mode, where you're failing safe. Because imagine the days, I know when the self-etch adhesives came out, we thought about, very cleverly, we thought about the use of just etching the enamel and then use the self-etch for the dentin part, which is great, right? You're getting the best of both worlds. But what happens if you get a little bit of etchant on the dentin? What happens to your bond? Good luck, who knows? Here, you fail safe. No worries with that. So just want to reinforce that's a very important feature too. And also here you're talking about, because of you're loaded up with more photo initiator, you're dealing with a 10-second cure time, HEMA-free, which was a concern in the 90s. I remember living through that, the concern that the dentin bond would degrade, hydrolysis over the years. So here, getting rid of HEMA is a very important factor, as you saw from the scientific research. What happens to HEMA when it gets imbibed with water, right? It gets kind of flexible like that too. Acetone-based, because acetone chases water the best, but it's not overly aromatic, like some of the products that we've seen that smell like nail polish remover, right? Nothing like that. So the sensitivity is less of an issue. And I say that dealing with the 90s, where we were worried about how dry is dentin? Is it too dry? Not dry enough? How's that going to affect our bond? And most importantly, sensitivity. Is the patient going to come back with problems? So we have to redo a restoration. That's been solved, which is a tremendous innovation too. And you look simply how to manage this. It's very simple. You're applying this. If you want to use it in a self-etch scenario, apply for 10 seconds. And I'll show you where I use it in different modes. Cure, 10, right? And then your air dry course, and you're good to go. And you look at your bond strengths in general, how you're running well over 30 megapascals, like I showed you on that little pull down chart. So you're right there, convenience factor, okay? And that's where this product comes in. So you're getting rock solid bonding with convenience. Now, some of us prefer a 2-bottle system. Why is that even an issue when you think about it? But there is a well-established school of thought in our profession that Optibond FL is the gold standard. You've heard that thrown around all the time, which was true. Let me say, it was true. Okay, you separating the bottles, you're getting the best of each feature, hydrophobic and hydrophilic as that goes. So GC created G2 Bond Universal. So let me talk about this product because I've been using this year now, and I have to tell you, I'm very, very pleased with it. And the reason you're separating out now, you lose a little bit of convenience, but it's not an end of the world scenario by any means. But by separating out the elements, what's hydrophilic and hydrophobic, you're able to get the better bond on each substrate. So of course, hydrophilic is better for tooth structure, right? And then hydrophobic is better on the plastic or the resin side, in terms of the chemistry, right? And of course, you're dealing with HEMA-free. So when you do that, with the addition of MDP in there, look at your numbers. You're getting 40 and north of that megapascals of bond strength, okay? That's pretty amazing. That would be unheard of in the 90s. Unheard of. And it's thanks to that functional monomer MDP. That's really what makes it happen. And you saw that on the chemistry review too. So that's really the key with this. Also, you have compatibility with everything. No worries with that. That's in the past. Also that with the increased film thickness, which is in the neighborhood of 35 microns, you're going to get better marginal protection, less micro leakage. So that's the point of doing this. And again, application is very, very easy. However you want to do this in a self-etch mode, whatever you prefer, 10 seconds, air dry, apply your primer first, air dry, and then your light cure after you apply your resin, and you're all set. So it's analogous to that Optibond FL scenario, but here you have a different version of that too. And then also on your post scenario, same scenario like this too. And I'd let you can read the instructions on the PDF as far as this goes to explain to the docs in our courses. But you look at a separate review of everything here, from Dental Advisor, look at how this stacks up against Optibond FL. Look at the difference in megapascal bond strength to enamel and dentin. So who's the gold standard, right? Think about it, right? That's a big difference. There's a tremendous innovation, tremendous product. And then on the other side of things, on substrates like zirconia and gold alloy, look at the bond strengths you're getting to zirconia with that in excess of 42. So it's tremendous, tremendous innovation. All this is available to you as far as the stats go. So when you think about it, what's really the gold standard today on the two-bottle system? It's really G2 bond. And I think of it like this, I describe it like this, because of the protection of that fail-safe mode, which you do not get with Optibond FL, I think of it as Optibond FL on steroids. That's how I explain it to the participants in my course, so they understand what they're managing. So if you're happy using Optibond FL, then it makes sense. Why wouldn't you upgrade getting the benefit of MDP, right? It's kind of common sense when you think about it too. So it's tremendous innovation and it's a great product. Be mindful that the increased film thickness can be an issue for cementation of veneers. So it's something to be think about. And I'm going to show you where I use when, by mode, and by product. So like I say, you're not getting the benefit of that self-etch mode with Optibond FL. That's not there. No fail-safe on, right? And no MDP. So when you think about it, why wouldn't you go for the upgrade? When I'm flying, I always do. Right? Same thing here. So when do I use which? That's a great question too. And I'm going to break it up because there's a convenience side, versus the extra strength and greater film thickness, as I said. So if I may break it up in this scenario, let's go by mode. So in the total etch scenario, which typically say like a class 3, a 4, and 6s, here, class 4 scenario, I'm going to go with the G2 bond. Okay, I want that strength. I want good marginal integrity. The film thickness is not an issue for me. And this was done with GC Sculpt, as a matter of fact, this case. Okay, 2 shades, as I showed you. Same scenario here. When you're getting into these little micro restorations, which I typically do in Genio Universal Injectable, I'm going to go with G2 bond. Cases like this, always get a night guard fabricated if it's related to bruxism. If it isn't, if it's a, how would you say, like precipitating event, biting on a fingernail or opening up something, okay, it'll survive pretty well because it's already in an envelope of function. You don't have to worry. You look at these class 6s anteriorly. Excellent place, Genio Injectable Universal, and this is a great place to use G2 bond. So I would definitely lean on that in this scenario. And by the way, these are something I've been talking about for many years. I've been treating these for about 22 years now. And if you go back and look at a 22-year-old case, which was done with compactable composite at the time, which could have been in the neighborhood of maybe 13 microns per year wear, it held up pretty well for 22 years. And as a matter of fact, had someone in the chair just this week. This is about a 7-year-old case of Genio Universal flow. It looks pretty good to me. So these are the areas that you want to treat. I always open the door to docs, and it also helps the doctors understand where they could start using injectable composite as well as the adhesives. It's a really easy way in if you're doing class 5s or class 6s, because these are ubiquitous. They're everywhere. So at the end of the day, you definitely, it's opening up a new center of productivity in your practice. So here, a posterior class 6. Again, why wouldn't you treat these lesions? What would you want in your own mouth, right? You don't want to leave open dentin. So again, using G2 bond here and total etch. Why? Because in all these cases, I'm not concerned about sensitivity at all. Not going to happen. So I'm not worried. So I'll go with the total etch. Here, that case I showed you with the hypercalcification spots, same scenario. Not worried about sensitivity there. So G2 bond is great. And also finally, using what I call, like my little name, I call it like minimal prep bonding. So I'm taking a case, I'm simply micro etching with aluminum oxide particles, 50 micron, and I'm applying injectable composite strategically to create the smile. Here I repaired a class 4 too. But a case like this, again, that increased film thickness, that strength, I'm going to go with G2 bond now that it's available. Core scenarios. On an endodontically treated tooth, here I'm using Everex Flow. Okay, why wouldn't you want the extra strength? There's no sensitivity issue here. So go ahead, etch away, and then load that up with material, and you're ready for the crown. I'm not worried about anything. So G2 bond is perfect in that situation too. Also, my version, which I've been doing for about 20 years, of a space maintainer. So this is something that I haven't had published, but I'm using a fiber post in essence. And it always disturbed me that a patient, little Johnny, would bite in pizza crust and break that little shoe right off. And I'm re-cementing it periodically for him. Say, all right, I'll fix him. I'll put something in there that's not going to come loose. Of course, it's done with the thought that you're going to follow up every couple of months, inform him and mom when that tooth is coming through, come right back to me, and I can just trim this off with a burr, polish it up with discs, no harm done. These don't come out. So I'm just using fiber posts, and here's a great place to use injectable composite as well as G2 bond. So this is my own little version of that. Like I say, the tooth comes in, remove it, and you're all set. It works out quite well. Just follow it up. That's the key. Going to the selective etch scenario. So now obviously we're concerned. Not that dentin hypersensitivity is an issue with today's adhesives, but in general, I like to be extra cautious. So here, and I'll go further into why I do this, I prefer to go selective etch. So say like on the class 1, class 2s, and class 5s. So there's another reason I'll discuss. So here's a novel way to approach a class 2, a window of opportunity. You can get direct access. That's getting closer to the pulp when I excavated that out. So here, treating that with G2 bond and injectable composite works out really well. But in fact, you could use either or here. So either or is fine. Like, it's a matter of convenience, like I say. I use both. I have both in my office. I use them both routinely. Here, using a class 5 scenario, I will also selective etch, and I'll tell you why in a moment. But here, I'm going to favor the G2 bond. The reason that I prefer to selective etch is, in this scenario, is because I attended the International Academy of Adhesive Dentistry meeting a couple of years ago. It happened to be in Philadelphia at Penn, and I got to see Junji Tagami speak. And he discussed superdentin. Bless you. And no one told me about superdentin. I was a little upset, to be honest. So why didn't no one talk about this? It's 10 years old. So I kind of dug into it a little deeper and to find out how do I apply that to what I do in terms of anything. And I don't have a lot of time to get into it, but I'm going to talk about it briefly. So I ask you, if you just Google superdentin, you'll see Tagami and look into it. In essence, what's happening is when you're bonding with no bond is one scenario that you see here on the left side. As you move to the center image, bonding with total etch, you're wiping out that smear layer, which will allow you infiltration into dentin tubules. But with self-etch or selective etch on enamel, you are using the smear layer, or may I say, plasticizing the smear layer as your hybrid layer. So why is that important? What is the superdentin concept? When you plasticize that, okay, now it's resistant to acid and base degradation. Lactic acid from strep mutans, obviously, or any other acid pH issues in the mouth that we have with beverages, whatever it is, okay? That's the protection you get. So where do I want that protection? I want that up at the gingival area where maybe I'm on cementin, okay? I'm on cementin there, maybe no enamel, it's at the cervical. And I remember years ago speaking to some R&D people about the fact that they said, we noticed that when the self-etch, those 6 generations came out, we noticed that there was less micro leakage with them in the areas of dentin on class 5s. I said, oh, it's interesting. I put that thought in the back of my head. Always remember that. And then when I saw this, I said, I understand what's going on. Makes sense. So like I say, that's where I want to make use and take advantage of that. It offers additional protection in that area. Please look into that. It's worth doing, and it gives that less chance of a breakdown in that spot. So that's where I'm creating that superdentin. And here, strength is important, and I'm going with the G2 bond. Okay. I micro etch before that. By the way, it's not imperative, but if you micro etch, you're going to generate automatically, say, like nominally speaking, maybe a 10 micron area, a smear layer that you can work with, that you'll hybridize, basically. The other place where I like to selective etch is when I'm down at the floor of proximal box, especially if I don't have enamel down there, okay? If I'm the first one in, of course, I'm going to leave that enamel protection down at the floor. But let's say there was a large amalgam that went deep and you're in a situation. Yes, there are other options, sandwich technique, a lot of different things you can use. But what I do is, in my opinion, this is the way I go. So down there at the floor, I want superdentin down there. I want that area closed up. Good marginal integrity, minimal micro leakage. So I do not etch down there. So that's the second reason. And then here you could use either or. I bounce back and forth. I would say, like a lot of these posterior cases in this situation, I tip a little for the convenience. So G Premium Bond is fine. But again, either or is available to you. I leave it up to you. This is my humble opinion as to where I put each product when I use both. Where am I going to go self-etch when I have a vital tooth? Endo's not done, and I'm building up a core. Okay, so that's where I want that strength, and I'm self-etch, obviously. I'm relying on the smear layer from my hybrid layer. I don't want to excite anything close to the pulp, so that's why I do that. And here, I would definitely go on the strength side for the G2 bond. Okay, just keep in mind briefly, I'm sure you've seen this before, and this is in a process of evolution also, is that your lights have a footprint. So there's a hot spot in the center and cooler. So if you're kicking, say, nominally speaking, 100 milliwatts per centimeter squared in the center, you might be on the periphery in the neighborhood of 800, 600 maybe. It varies. So what does that mean? As this evolves, and we've seen laser curing released now too, which I'm curious to see how that works out. Getting a beam collimated to be 8 millimeters. In general, you want to make sure that you're moving your light a little bit also, and of course, what I call kind of like overlap the curing zones. So on a class 1 like this, you definitely want to cook that composite, say in 3 zones, because if it's not cured, it's not composite, it's oatmeal. It's going to wear very fast. So keep that in mind. And then of course, if it's a class 2 scenario interproximally, you want to get right in there like this and cure that. So you're getting the corners, especially down deep of the proximal box. I've been practicing in my office now 26 years, and I do a lot of cosmetic work, but I also have a great general practice side, my hygienist. And I can tell you right now, when patients come in for their hygiene checks, I'm always looking at my restorations. And I would say on average, I'm running probably on composite restorations, which I haven't done an amalgam in 26 years, probably about 15 years I'm running. And it's not because I'm a magician or I'm a genius. It's because of that, what I'm showing you. I make sure that everything is cured to specification. It's very simple, because if it's not cured, it's not going to hold up well. And that means checking your lights too. So here also on the class 5, getting back to that, you want to make sure that you cure in zones. And there's even a case to be made, maybe curing a little, fading a little mesial or distal, moving the light slightly also. So you're kind of like garden hose spraying it with photons is good. It makes sense to do that also. Very minimal light. I cure everything myself. I don't let my assistant do it. It's up to you what you want to do, but make sure it's cured well, because you're the one that's got to repair it if it fails. In a scenario like this on the anterior class 6, if you don't cure that material, that's not going to wear like the case I showed you. That's going to wear out and hollow out very quickly. So it's hypercritical in this situation to cure that well. So just keep that in mind. It's something to convey to the participants of our courses. I'm trying to show you how I express myself to them so they have tremendous takeaways that tie into the products that I'm showing you too. So there's a lot of value for them, what they used to call pearls back in the day, but it's all practical stuff. So you have 2 great options. They're both exceptional. They both work. And I invite you, you've probably been using them already. You've probably developed your own opinions, which is important, which you like, where you like it. And to me, they both work out well. And it's a great option having a 2-bottle system on the menu for GC, because now you have something that is in essence the new gold standard, or as I said, Optibond FL on steroids, all modes, very different from the original. Let's talk about cements briefly. You look at the 100-year history of GC and their first cements. It's really been a legacy of constant innovation when you think about it. And that's a tremendous statement to the company and how they are focused on quality control, excellent products. Just look at the glass ionomer side of things alone, which people are going to speak about today. I mean, going from Fuji Duet, which I used around 95, maybe up to 2000, all the way up to where we are now with Fuji Evolve and GSEM 1. This is a tremendous coattail to rest on. Tremendous foundation for them. Think about this, 17 million restorations. Past week, patient comes in, woman's almost 90 years old, had a PFM I cemented on tooth number 15, and it was cemented with Fuji Duet, okay? Liquid capsule system, triturated, came loose. Let me tell you one thing. You say, okay, so that was what? It was probably done in the late 90s. It was over 20 years, which you say, that's pretty good in itself. It gets better. This was because she was kind of obsessed with not showing any metal margins. This was a porcelain butt joint PFM. So in other words, no ferrule effect. Think about the retention on that. That's like the retention today with zirconia crowns in the digital world, not that retentive. and yet it held up over 20 years with Fuji Duet, okay? And this woman bites hard. She's got some wear. So think about that. That's a tremendous legacy that you have. And that's also a tremendous amount of confidence that you want to impart to the participants in our courses about the cement side of things. That's a tremendous record. So looking at today, moving into all ceramic restorations, it's important to have that ability to cement things in that are less retentive. You know, whether it's zirconia or Lisi press, lithium disilicate, we need that option. It's not like the days of a gold crown or a gold inlay or onlay, where the gold crown, you could press that in position and actually deform it a little bit, get what we call in engineering an interference fit. And the zinc oxide phosphate cement that you put in there, it wasn't about retention. It was a little bit. It was about sealing up that micro gap, right? So nothing leaks in there. But in fact, you know what I'm saying. Some of you have put those on years ago. They don't come off that easy unless there's a little removal button on there that holds well. We don't have that anymore. You're in the digital world. So how do you read those sharp angles? You don't. But that's okay, because we have cements that can manage that for you. And that's what I'm going to talk about. Again, a case like this, a resin retained bridge that I did, zirconia framework, baked porcelain, a little bit of pink porcelain for you there, okay? Something like that, who would even think about that years ago? But you need retention. And in fact, bonding to zirconia today is better than it was bonding to the alloy that we use for the classic Maryland bridge that was typically tin plated, if you recall, to enhance your bond strength. So this will hold up better bond strength. So you have to look at what your options. Do you want to bond or cement? And as I mentioned, things that are less retentive or that don't obtain strength because inherently they're strong, they require strength get strength through lamination, then you got to consider you're looking at more of a resin-based cement. So you have two options. And that's where GC is covering both those camps on that side too. What I want to say is also when it comes to products, not lithium disilicate, of course, but zirconia, micro etching is very important to do, as you would explain to the participants in your course. That's critical. And if things are micro etched in the lab, not chair side, then you can always use an Ivoclean or a product like that to manage it. But let's talk about where we are on the resin modified glass ionomer side with Evolve. So I've been using this a while, and this is an exceptional cement, exceptional cleanup, and show you how this is kind of evolved, as the name suggests, from the other products that I showed you, especially Fuji Sem 2. So what you have now is this has been modified and adapted for the zirconia crown. This monolithic I'm referring to, okay? You're getting north of 15 megapascals of bond strength to zirconia, not with MDP, but just because of wettability. So you're getting easy delivery system, and the ease of cleanup with this in terms of, even without tack curing, which is not necessary, I usually just wait it out. Of course, full set, 4.5 minutes, but wait a minute or so, and all of a sudden you can start pulling away the material. It doesn't get easier than this. I wish we had this 20 years ago. That combination is just phenomenally easy. It's great. You're not gouging into the tissue. I notice even because we're so kind to the tissue, we're not going that deep subgingivally that I classically, on the temporary stage, if I'm doing this with a lab, I will use some injectable composite to lock in mechanically, lock in my contacts on the temp. No flossing for 3 weeks, no worries, so that they don't lose the temp, because it's that how would you say, non-retentive, relatively speaking, to the days when we would do PFMs and go way down subgingivally. So the tissue is pristine with this. So again, ease of use, you can't get any easier than this. The preparation, the zirconia, cementing with this is really super, super easy. And again, like I said, you're getting that extra bond to zirconia that I mentioned to you. And you're having a scenario where originally when glass ionomers first came out, I remember back in the maybe late 80s, actually covering the crowns, in addition to isolation, covering the crown with like a little foil cover to protect it from moisture, thinking back, because we're concerned. We knew that water solubility was great that first minute or so. That's changed. Look how user-friendly things have become thanks to the development, the R&D that GC's presented. So now, no worries with that. You don't pre-treat with anything too. Goes right on the tooth. As I said, just micro-edge zirconia, of course, for the mechanical retention, okay? And it really is super easy to manage too. And also what's happened too is you've got a more flexible cement in itself. So if you imagine as a person is crushing into a crown, if it's flexing, less so with ceramic, more so with metal, they're cracking the cement, developing microfractures. And as the years go by, that's what leads to cement washout, right? So here, that's managed with a more elastic cement. So between all that, tolerance of moisture is really a tremendous innovation, and it can't get much easier. I can't imagine what else you could do to that to make it easier for me, unless it like cements itself. Something like that would be great. But again, that wettability to zirconia is giving you that bond strength that you have without having to prime. So it's something that I take advantage. And I haven't had one full contour zirconia crown come out with Evolve or Fujisen 2. And Lord knows how long I've been, what could I have, like maybe, could I have maybe 1,500, maybe 2,000 in the last 8 years, 9 years that I've done. It really worked out quite well. So I'm very happy to report that. So here, you can also use this if you want to cement inlays or onlays. Like on occasion, I've done zirconia onlays, full contour, where the tooth is very, very shallow, tooth number 18, hard to do a crown. I can get away with it. This is a great place to do that. So you can be creative. You know, we're all pretty creative in this room, come up with new applications for it. But things that have strength on their own, obviously, that don't get strength through lamination, that's where it's available to you too. So PFMs, of course, zirconia crowns works out well, and that's you want to take advantage of this, the ease of use that really can't be beat. So like I said, when you look at Glidewell's Bruxier crowns, gold crown, this is really where you're going to go with this. Ease of use, just the cleanup is so nice. It's so sweet. Let that set maybe about a minute or so and just pick that away. I don't worry about lubricating the tooth, the crown at all. Not necessary. Cleanup is exceptional. Like you know, nothing I've ever used before. Really worked out well. And as I mentioned, the bond strength then with zirconia, that's the thing, that the advantage is that you're getting that. It's interesting because a lot of docs, as you know, in our profession, with all due respect, there's a comfort zone issue. They'll lock in on that one product. You know, I really like Fuji Duet, or I really like, you know, whatever it was, and getting them to switch out is kind of our job, right? So that's where showing them the whole concept of the evolution of, and what they're getting. What are you getting for switching out? You're getting an easier procedure, right? That's what makes it, that's the carrot that you dangle. That's what makes it inviting to do. You're getting all the features you have with the previous products. They're all great. You got that. No worries. Plus you're getting this, and cleanup is easier. So that in itself is something that's worth explaining to them so they can kind of understand why it's worthwhile changing. And again, cementation, I'll let you look at the guide. Very simple, like I said. You know, I know there's even an option. Sometimes you do have people that like to hand mix. I'm not sure why you would do that. To me, you know, time is money. So you really want to, it's about patient comfort too, less chair time, you know, do the procedure, you know, improve the quality, but less time. That's the win-win situation. So using the syringe that's provided, mixing syringe, to me, it's, you know, it's a no-brainer when it comes to that too. And the result is great. Let it set, and then you're all set. So that's one option too. And like I say, I also, by the way, I do micro etch the preparation because I want to clean any residual cement off. And if the docs are using Gluma as a desensitizer or any equivalent thereof, any hemo equivalent in this situation, I think there's no interaction from what I was explained to me. So it's fine. I do it routinely. And with the micro etching, the prep itself on a vital tooth, I had stunningly no sensitivity on crowns, unless I anticipate them needing endo. So that's going in. But without that, really, not like years ago where you could get that on occasion. Not at all. Not at all. So like I said, if this is not coming back from the labs can micro etch it for you. If I do a chair side typically because you want it micro roughened, the way Christensen explained. I remember a funny story. I was always disturbed, the mechanical engineer thinking now, not so much the dentist, the intaglio of the zirconia crown would always have that kind of like satin look. And I said, you know what? That should look more like frosted when I micro etch something else, like you see with lithium disilicate when it's treated with hydrofluoric acid, right? So I went on Amazon, got my hands on some diamond powder. I said, all right, I'll fix that. I went in there, used diamond powder on it, put it in my micro etcher. What did I see? The same. So what's happening is is at the microscopic level. So yeah, it does contribute to retention if you're micro-etching it. It's not about the bond to zirconia, but you want to clean it. If you're bonding, you can use a product like AvaClean, but to me, it's really superfluous now if you have something chairside. So now, that being said, ease of use of Evolve, resin modified glass ionomer cement, which is great, works well. What if you need more retention? What if you're dealing with a resin retained bridge? Okay, some zirconia crowns, maybe short prep. I don't want to say that they fit loosely, but they're just not retentive on that path of draw. So how would you manage that if you're looking for that additional retention? And of course, lithium disilicate. I typically do not cement that in with resin modified glass ionomer. Even though you're in the neighborhood of 600 megapascals of bond strength, you could do it, but I prefer to bond that down. I prefer to do that too. So that's where GSEM1 comes in. And what's great about this product that I've been using since I think it came out around April is that what GC has done is they've kind of taken the two products of Link Force, if you used that before, okay, which you have to use with the dual cure bonding agent, and resin modified glass ionomer cement like Evolve, and then fuse them into one product. So what you have now is a self-adhesive resin cement that cleans up like a resin modified glass ionomer. That's why this product's a home run, because the cleanup is a breeze, easy. And I'll talk about how I manage that too. There's another little issue about that too, but it's great. Here you have this enhanced primer that's available, which I typically use all the time. I like it. I want that extra bond strength. You're in that neighborhood of over 40 megapascals of bond strength, so I'm taking it. I'm going to get all the strength I could get. Okay? So it's an option, but I have to tell you that I always take that option. And this helps you on the dual cure side also. That's an important feature. Shades, it typically, an A2 shade is fine. If you're doing, obviously with self-adhesive cements like this, dual cure, this is not for a 10 veneer case, needless to say, okay? These are for bridges. Single veneers, yes, I'll do. 2 laterals, that's fine. I've done it in that scenario. Maybe 2 centrals. Something where I have a little time to control everything too, because the set is going to go fast, and you want to make sure everything is well seated in that scenario. So for that, and of course, the white opaque, you can modulate the shade a little bit. All those colors that we had in between when it comes to the veneer cements, I find them superfluous. But I do find a translucent and the bleach white or a white opaque, you can get a little more pop. I just inserted a case this week, get a little more value, a little higher value if you go with the opaque. So I'll do half and half when I try in and look at it myself, then let the patient look and decide. So there's definitely merit to having that. But in this case, you have shades that whatever that'll cover you for all the contingencies that you may have too. So here, this touch cure technology is referring to the fact that by putting the primer down, when you're putting the resin in the crown or whatever you're cementing, when they come together and they touch, you're getting, as you saw in the R&D video, what they call a dark cure, or to us, it's really auto cure or chem cure. Because how do you know you can get light down deep? And in fact, you can't. So you want to make sure. If you look at just the fact going through zirconia or lithium disilicate, if the light that you're using is 100 milliwatts per centimeter squared, you're getting down to 5%, like 50 milliwatts per centimeter squared. That's not a lot of light. So that better dual cure. Otherwise, that crown's not going to be cured. The cement's not going to be cured properly. So there's tremendous merit for that. Look at bond strength of dentin. Notice with the primer, where it's in that 40 megapascal range, okay, to other restorative materials. So to me, I use it on the dentin. I like that. I take advantage of that all the time. I want as much strength as I can get. Wear resistance, like with other products, is low. Nominally speaking, 3 microns a year. Why is that important? Years ago, when we started doing a lot of cosmetic work, porcelain veneers, there was a school of thought, and I followed it. Don't let occlusion occur, say centric or anything, I guess, on the margin, because that cement could wear out. If you're using a GC product, no worries. It's going to wear like composite will, like those class 6s I showed you. So that takes that off the table. So there's no need to worry. Other products, I can't speak to that. But here, I don't worry about that anymore. So I put that margin where I need to, where I see fit in each case. So like I say, that's something that's true of all the products that you're seeing, because it's all the same nanoparticle technology. So that's a great feature that's built in. That's organic, that's native to their composites, right? Here's something very fascinating because, of course, in dentistry in general, isolation is critical. And you decide if you want to do it by rubber dam, four-handed dentistry, whatever it is. In the days when we did not have such moisture-tolerant or hydrophilic adhesives, the concern was the humidity of the mouth, which is 100%, could be an issue with bond strength, right? I'm talking 90s now. But that's no longer an issue. So I don't worry about the humidity of the mouth anymore because the adhesives are hydrophilic. But salivary contamination, that's not good. We don't want that, right? Now, that being said, what if, by accident, of course, you happen to get a little bit of saliva on that prep? Well, have a look at this. It doesn't change much with GSEM1. And I had to have this article translated from Japanese so I could understand it and read it. And that's basically what this article is showing, that no decrease in bond strength. Now, I'm sure this is not being cemented in a pool of saliva, okay, like you could do with amalgam, and it can work quite well. But God forbid there's a little contamination, at least you know, it's like that concept of engineering I speak of, you fail safe, which is important. So you have a great bond to the tooth, and you're not getting hurt by that. Not that we recommend it, but we know the reality of clinical practice. Sometimes it could happen. Okay, we try to be as meticulous as possible, but that's a very nice thing to know. It's something to mention to participants in our courses, because that's a great feature, great feature. Look at the bond strength again here too, with that primer. I go with the primer for everything. Why not, right? Go for the max. Look at the strength that you have. Okay, 40 megapascals of bond strength. Here's Dental Advisor's report on the product too. So let's just go through one thing at a time. Look at the enamel with the primer. Look where you are, right? 40 megapascals, okay? On dentin, 40 with the primer. On lithium disilicate, Lisi Press, you're up in that range, 50, but this is where you do need silane. So you're going to use the multi-primer. You do need silane for that. Just keep that in mind, always, a general rule. And then, of course, zirconia, you don't need anything because it's loaded with MDP. So the days of having to prime zirconia are pretty much over when it comes to something like this. And look where you are in the neighborhood, like 50 megapascals of bond strength. And that's important on your resin retained bridges, of course. Again, ease of use here too. I always take the option of applying the primer. So I would definitely use that. It's what does it take? Another few seconds to get a great restoration. Remember, you're the one that has to redo everything if it fails. So you want it done quickly and properly, meticulously, and done with a high level of quality. So that restoration will last a long time. It's obvious. Now, let me just say one thing about this too. This cement is so good, so adherent, that when I started using it, I noticed that if it got up in the contact area, I had to get that out of there fast. Tout sweet, as they say en français. So as a little thought, I started to put a small amount, carefully placed, not at the margin, of course, Vaseline on the contacts, on the tooth, and on the crown. And I'm using what I call like a nano brush. So the real small version, what is it, like a 0.5 millimeter tip of the micro brushes, disposable micro brushes. Get a little Vaseline on your glove, small amount, just lightly wipe that area. So that when you're going through there with floss, it cleans through nicely and it won't adhere because it sticks that well. Around the margin, not really that much of a problem. You can clean that out. You can either wait it out. You can wave cure it if you want. Very important issue with any of these products that are dual cure, which means that they're chem cure or auto cure. Polymerization is a process that occurs in time. So as substrates, monomers come together to become polymers, that happens in a timeline. So what does that mean in terms of chemistry? Make sure you give any of these products a minute or so to set up. Let that cross-linking occur. Don't rush it. Don't freeze it up prematurely by curing it and not allowing that cross-linkage to occur. Just a little side note. And again, that may change in the future, but as far as I'm concerned, knowing for what I know the days of chemistry back in college and high school, polymerization occurs in time. So give it a minute. What's the rush, right? Polymerizes, then go ahead. Maybe at that point, you may find you can clean up very easily, pick everything away from the Explorer. You may want to wave cure it. If not, and again, 4.5 minutes set time, that's rock solid. After that minute, I'm going to go in there with floss and clean up the contacts. Because I Vaselined the teeth and the crown itself, I have no problem removing that. So that's a great tip that I learned from using it. It works out well. Don't contaminate the margin, of course. That's the only danger with that too. Same scenario, if you're using this on a post, follow the same thing. I would use the primer. Get all the strength you can. It's a great enhancement. So clinical advice when it comes to these, just generally speaking, like if you're doing full contour zirconia crowns, I presume that everyone hasn't manufactured CAD/CAM from a puck. So if you have to adjust occlusion or recontour it, you're cutting through solid material. The ones that are bleach white, that are doped, before they sinter down, if you cut in there, all of a sudden you're looking at white, right? So you want to make sure it's done from a puck if you can. And then basically you can use Evolve or resin modified glass ionomer for teeth that have inherent strength, which is typically high strength zirconia. You can Lisi press, and that's pretty much posterior dentistry. I typically bond the Lisi press. Any high translucency zirconia, that's where you want to do the bond to, right? And any veneers, I've done zirconia veneers. I've done, on occasion, I do them. Of course, you're going to bond that. So now you have something to bond that very nicely and cleanly and expeditiously. You look at where we are with adhesive dentistry. I mean, adhesive dentistry is fire. It's unbelievable where we are. Anything is possible. And that's what I've witnessed in my 35 years of practice. Things that I never thought possible. Here's some kind of like exotic uses of the products. Patient comes in, front tooth is fractured. This child came in, endodontic treatment was already rendered on tooth number 9. So what happens, comes to me, and believe it or not, don't you know, they had the missing fragment. I said, wow, so happy. So now what are you going to do about it? I want to glue that back in place if I can. And the little issue is curing down deep where the dentin is. How does that work out? And giving it strength. So what I did at the time, I used Link Force with this. Today, of course, I would use even a simplified version now. I'd use GSM1. And you rehearse it, orchestrate the replacement, make sure everything's fine, micro etch each side, primer, obviously, and go, GSM1, lock it down in place. But now you're left with this funny little seam. That's not going to work. And how strong is that? That's the concern, right? So you want to bolster the strength up again. And what you do is then I typically will just do like kind of like a shallow bevel, like a trough of sorts on the facial, and micro etch again, adhesive of choice. And here I would use Genome Universal Injectable. Go ahead and fill that in like so. And then to top it all off, now you want to go on the palatal aspect and place a fiber post, right? You want to have that supported. I've done this a few times in my career and not one of them has fallen out, but everyone was done to this protocol. First one was probably 20 something years ago. And again, using that fiber post, generic fiber post at the time that I used, supports that. And then remember, think about it, when it's in the existing envelope of function. You're not lengthening the tooth, right? You're not putting it in harm's way, anterior guidance. You're taking advantage of the fact that that's where it was before. So if you can do that, not that any of you in this room couldn't create those incisal translucencies with composite, but what's the path of least resistance? That is. And the key is to make sure the curing is done down deep where the dentin is. So with a dual cure product like this, you know you're rock solid and you're getting, especially here, 40 megapascals of bond strength. Okay, you can't beat that. Very helpful too. Another quick scenario of the endodontically treated darkened tooth. So I know that this can be treated with a variety of ways, anything from the most utilization of a crown to a veneer. But the thing that disturbed me about this is that it always was an issue of the optics. I would like to have something that is optically, as I optically dissect the neighboring tooth, similar. So how do I create that? If I have to block something out on the veneer, an opacious layer, and then put a translucent layer, that can work, nothing wrong. But how do I replicate what I have next door? That was the issue. That's what bothered me structurally when I first started doing these, probably well over 20 years ago. So I said, what if I manage this with composite? What are my chances here? So number one, I have to get rid of that hemosiderin stained dentin. So I get rid of it. And when you think about how I'm gutting that tooth out, it gets you a little nervous, right? So I've got to go in there with a post. But fortunately, I have a dentin replacement called composite, right? Similar modules of elasticity. Get that in there, load it up. And this is done over 2 visits. Because the first visit when I do this, the patient is desiccated. So I can't read the shade properly. And I'm going to shift the shade a little bit, right? By getting rid of that hemosiderin stained dentin, I'm getting a better shade. So I got to let that sit. Do the post, seal it up, dentin shade on the lingual, okay? Like this. Come on back in a week after that. Then I treat it on the facial aspect. So now I'm going to do kind of like a veneer prep, but I'm going to channel in carefully, since that tooth comes to kind of like a constricted neck at the cervical, right? Go in there with care. I might get down maybe 2 millimeters subgingivally within the confines of the tooth, okay? And notice, remember, when the tooth is stained with hemosiderin, it's the whole tooth. If you extracted that tooth, the whole tooth is black. It's not just in the area that you see. So you got to cut that off. And you can see how dark it is when you look down on the root on that kind of like that axial view, right? When you can see the bulk of composite that I created, which of course has the fiber post embedded in there. So then what are you going to do here? This is where you definitely want to go with G2 bond, right? So G2 bond, something strong. I'll use XPW, something very white to block out that darkness of the root area. And I'm tucking that in down deep. Notice the contacts were not opened. Incisal ledge was not touched at all. I'm just channeling into the tooth, kind of inlaying, if I may say it, with composite. So I'm creating something similar to the neighboring tooth. Go ahead, put your dentin layer down. Just keep that off of that cervical area. Cure it. Your enamel layer. And then here with the enamel layer, you go ahead and you just tuck that right in using our favorite IPCL instrument from Cosmonet. Just tuck that right in place like this. Right, just maybe subgingivally. You got a nice closed margin and you're on enamel. That's a rock solid bond, right? And you have a finished restoration that matches optically. And I've probably done maybe shy of a dozen of these, but not one has snapped off or broken. Again, I'm stacking the deck in my favor. It's in an existing envelope of function, right? So all you need is the strength of the tooth that was there and you're okay. And that occurs with the post and you have a great result. So if this stain, the composite broke down in time, it could be redone. It's a different scenario than going in there, gouging it out with a crown, of course, the soft tissue, or doing something that takes more tooth structure away and doesn't give you the same level of optics. So that was the driving force here. Was I a little concerned when I did it the first time? Of course. But it's something that worked out well, and it's something that I do when that situation comes in. And now having products like G2 Bond is tremendous, and to cement the post in with something that's extremely strong is even better. Yes. Oh, okay, very good. I'm going to finish right up then. Okay, so I want to thank again, thanks so much. I want to thank GC for having me speak and congratulate them on their Deming Award, which is a measure of highest quality in total quality management and a reflection of the quality of the products. And again, I want to thank you so much. And I saw their factories in Japan. It was an amazing visit to Oyama, how meticulous everything was done there. And yes, I did get to climb Mount Fuji, as a matter of fact.
Amazing presentation, Robert.
Thank you
Thank you
very
so
much.
much. So we're going to keep you up there.
Yes.
You're not going anywhere.
Thank you. Thanks.
So we had about 300 people on the webinar, and they're still on. So they have a couple of questions.
Oh,
But-
yes. Tell me.
So everybody here could actually pose a question using the buttons on your microphone. So the button on the right, if you want to ask a question, just push the button once. If it's red, it's hot. That means you can go. If it's flashing green, you're next. And if it's green, you're in queue. So please feel free to use that button on the right of the microphone. You can ask Dr. Maris some questions, and we have a couple of questions from our audience at Viva Learning. So please.
Yes. Any questions here or? No? Oh, yes.
Thank you again. Congratulations. Beautiful.
Oh, thank you. Thanks so much.
In terms of the cementation, without the light, because obviously there's a chemical interaction going on.
Yes.
What is your share time in respect to that, such as, let's assume you are cementing a post, how much time do we have when you use the primer without the light?
I would say the question is when I'm using, say, in a post scenario, or even a crown, what's my typical setting time? I use without the light, and I tend to do it without the light initially and then cure when I'm done, but I'll let it sit at least 4 minutes, 4.5 minutes. So let that chem cure. It's not necessary, at least a minute when I was referring to cross-linkage polymerization, a minute at least, and then you can go ahead and light cure if you want. I typically let it sit because it's easier. Patient spotting on a cotton roll, sets 4 minutes, and then when I'm done, I go in there with the light, and I'm really hitting the margins. I know that I'm not penetrating through the posterior crown that well, but I'm getting the margins, I'm getting them sealed up. So more or less, say 4 or 5 minute time, if that answers your question.
So maybe R&D also can help in terms of full polymerization without curing light. Let's say we have patient with a high function, we are sending the patient away. How long will we?
Yeah, like 4.5 minutes. Is it? You're chem cured in 4.5 minutes. Isn't that true? Yeah, you're done. By 5 minutes, you're cured up. That's the beauty. You're not relying on the light, like that dark cure that was referred to.
Okay, so full polymerization reaches in 4 to 5 minutes. Or
Yes.
10 minutes, whatnot.
Without the light, exactly. Yes, that's right. If you let everything set for 5 minutes, you're okay. Yes, correct.
Yeah, to get another question, if you can push the button again, that'll allow someone else to ask somebody. Does anybody else have another question?
I have a question. It's Red.
Perfectly.
First,
Great.
excellent presentation.
Oh, thank you.
I have
Thank you.
2 quick questions. You could comment on the superintendent class 5 scenario.
Yes.
If you have, in a self-test technique, if there is sclerotic dentine present, can you briefly comment on do you still treat it the same way if it is sclerotic in class 5? And secondly, briefly, can you comment on your GSM1? If you're using the primer, you said, I just use primer almost every time. What about in a retention situation? Are you worried about having to take that crown off in the future? I'm just curious your thoughts on that.
Okay, I'll take the second one first. So yeah, I always go with the enhanced primer because I want the strength. As far as removing crowns, I mean, it's always work to cut them off. So I'm cutting a crown. I don't pull them off. I'm always afraid of breaking off the prep. So I just slice them, whether it's zirconia, which will fracture nicely with a coarse burr, cut right through, disposable burrs, PFM, same thing. So I never worry about that. I'm thinking on the positive side, I want this to hold in there for the duration of the longevity of the restoration. As far as the nature of the dentin on the class 5 scenario, where I'm looking to develop, the superdentin, it's really about, it's not about how many, say dentin tubules exist per, cubic micrometer, right? It's really the nature of developing the smear layer. Since with self-etch products, that's what creates your hybrid layer. It's the smear layer. So if you micro etch that, or if you prepped it with a burr, you got yourself a nice smear layer there. So you're good to go. So that's the key. It's about the smear layer, which is kind of like the sludge, right? Of dentin that we make. That's what collects with the acidic primer that creates that hybrid layer that's acid and base resistant. That's a great question. Thank you.
Anybody else have any questions? We have a question from Viva Learning, if that's okay.
Yes, Phil, of course.
Yeah, okay. So from our audience out in the cyber world,
Yeah.
what are the odds that when you use a fiber post for space maintenance, that the patient will bite on something hard and break it, and worse, swallow it or aspirate it? That's the slide you showed where you made that space maintainer.
Yes, of
using
course.
posts.
Yes. I have to say that I've done my own little version of a space maintainer. No one has broken them free. So it hasn't happened. Of course, anything could happen, but I use the concept that they're biting into hard bread. The kids bite the hard bread. So it hasn't broken out so far. And like I say, believe it or not, that was an Instagram post that I did that got about 50,000 views. You would think all the nice cases I try to portray, that's the one that was the most popular. Yeah, isn't that fascinating? But that's why. So I just wanted something that would be resistant to that, but it requires a lot of monitoring. So that patient should be back a month, 2 months, 3 months. That's a good question.
Any other questions from the audience?
So how's the color stability for the GSM1 cement, especially using on the Adhesive? And is it come with the trying paste or not? GSM1.
So say that again. I'm sorry. So GSM1, yes.
The color stability.
Oh, yes.
for Adhesive,
Oh, yes.
comes
Oh,
with the trying paste.
no, I haven't used a try and paste with that. But in general, when you're looking at, say, a resin retained bridge or a crown, zirconia crown, or lithium disilicate, it's really hard to modulate the color that much. On veneers, yes, but I haven't done that. Now, theoretically, I don't know if that will be something that's available in the future, because there is try and paste for link force that I use that in lieu of. So I will use that. It may not be the exact same, but you could, if it's hypercritical that you're matching maybe a central incisor, you could theoretically use maybe use that cement briefly and put it in there to try, but then you got to remove it quickly. To me, that would be playing with fire. But I would like to see a try and paste that correlates to that. That would be helpful. But right now I do use the link force version of that too. That's a great question. Maybe that's coming in the future.
Dr. Kamisi, you have a question? I think you have to hit your button to release the mic.
Oh, there we go. Very good.
And you should be, so green means you're in queue.
I have red on mine, actually.
Okay, whoever has red, go ahead and go for it.
So my question is, the use of the fiber post space maintainer,
Yes.
is that off-label use?
Yeah. Oh, that's black label use. That's a good question. Yes. I mean, I do it. I leave it. It's, in my opinion, it works for my needs. I hated having to re-cement little Johnny's, shoe band maintainer. So that's all. It was, necessities the mother of invention, right? That's what all it is.
You need to write a book on space maintainer.
I know.
It'll sell.
Oh my goodness.
Any other questions?
Did you have one?
There's a red light back there.
Yes, Robert, I was interested,
Yes.
I was interested in your discussion of the superdenting versus the sandwich restoration in the box.
Yes.
And like, if you could elaborate a little bit more on your rationale for going in that direction.
Yes, I mean, they're both excellent ways to manage because the superdentant is one way to seal those areas up, especially, the class 2 proximal box area where there is an enamel, okay? And I must say, before I was relying on superdentant in response to what you had to say, which is a very, very, very good point, Mark, what I would do is I would put glass ionomer cement like Evolve or Fujisem 2 at the time. I'd put a little liner at the base. So I was doing kind of like a semi-sandwich, like a little micro sandwich, if I could say. Why? Because I know that bond is rock solid of glass ionomer. I wouldn't put it on the margin, not on the band, but I put it in there. So if there was any leakage, then I was covering that with that zone of protection of fluoride. But since I got turned on to superdentant, I moved away from that. So like I say, and the reason I would use something that's an auto mix is I don't want any shrinkage. So I'd actually mix glass ionomer cement, Fujisem 2 at the time, Evolve for a while. And I would just put a little layer where I did not have that perfect little piece of enamel left. I'd run a little bit of that in that area on the floor, that bit of dent in there. So I knew that was sealed up, keeping it away from where an ultrasonic cleaner or a scaler during a prophy could damage it, of course, right? But the other option is why not go in there with Fuji Automex 2, go in there and create a little sandwich, protect yourself in that area. That works very nicely also. So this is just my way of doing it. That's what's great about our profession, that you have so many people that contribute to this continuum of knowledge, so to speak, that take a technique, modify it a little bit, come up with something new. And at the end of the day, we all benefit and the patients benefit too. That's the great part about it. But that's an excellent question. Thank you.
Robert, thank you very much for the
Oh.
presentation. A question regarding the interface between your adhesive and your restorative material. It goes counterintuitive to me that a thicker film thickness would be problematic. So could you explain greater film thickness and strength? Help me understand that there.
Sure, of course. So just speaking in terms of cementing a crown, I mean, what we kind of focus on is like, what do we say? Maybe 25 micron film thickness, is a good film thickness for cementing a crown, not to interfere with fit. So here you're 35. So what does that mean? So if it's a composite restoration, as you said, I'm going to go for the 35. So it's a little bit of like a thicker combined hybrid layer in resin. So you got a little more protection there. It's protecting the hybrid layer theoretically. So I'm fine with that. The concern is if you're cementing a crown or veneers, could it kind of shim that a little bit? That's to be seen, but I would be remiss not to make you aware of it. But on the side of composite, I take advantage of it. So that's an little extra thickness that's giving you more protection in terms of your hybrid layer. Because there's a school of thought, like once that hybrid layer is there, you want to protect it. Give you an example. I'm doing, say, class 1. So let's say I'm using G Premio bond. I'm using it in a selective etch mode. Go ahead, etch, apply the G Premio bond. So now the next step I will do is use a flowable composite and cure them together. Why? Because I'm protecting that precious hybrid layer that I created. I'm curing them together. Okay. So that's similar, that same school of thought on the engineering side, in my opinion, is why I do that. But just be mindful that could shim a restoration. That's why I make that point, just as kind of an awareness, situational awareness with that.
We could take 2 more questions. We have time for 2 more questions.
Yes.
I guess, just a comment.
Yes.
For so much talk about the fiber post
Yes.
space maintainer, there's a secret material that GC has called Everstick.
Oh, yes, I have that too. Yeah.
I tell you, I have used that for years with great success, including the space maintainer here,
Yes.
where you can etch a bond, labial, lingual, and use Everstick crown and breach to do that with less, I think, chance of having that breakage. But also, in cases where you're waiting for implants, worried about teeth super rough. This material, trying to ring the bell on it for a long time. And
Yes, that's an excellent, thank you, Bob. That's an excellent point because it's an excellent product. And that makes me think of an Instagram post with that product to turn people on. Yeah, thank you. That's an excellent point. Outstanding product to use.
Hi,
Hi.
thanks for an excellent.
Oh, thank you. Thanks.
A little bit of interest in this concept of protecting the hybrid layer because the hybrid layer is most likely going to get degraded from at the margin because it's exposed, and then from fluid within the tube that's moving towards the bonding area. It's hard to imagine much of anything is going to get through all that resin to get down to the hybrid layer to cause degradation. So it seems to me that it's almost impossible to really protect the hybrid layer itself because the dangers are always going to be there no matter how much resin you pop on top of it.
Yeah, so the hybrid layer is really a dentin phenomenon, right? So the protection that I'm referring to is mechanically. So it's not functionally. So let me explain. So when you're laying down composite there, you don't want to disrupt that because you had this beautiful uniform, in the neighborhood of microns, hybrid layer you developed, especially in the self-etch, right? So you took that smear layer and turned it into this plasticized hybrid layer. Now, when you cover it over with some flowable composite or injectable, now when you start packing composite, whatever you're doing, you're safe. But yes, of course, that's the whole issue. You're getting to issues like shrinkage, where if there's pulling away at the margins, can you get micro leakage? Yes, of course, on the functional side, that can happen regardless. But that's a great point. So thanks for clarifying that. Yes, it's a mechanical issue on the placement side. Very good.
Does that wrap it up, Scott? I think, yeah. So we really think, I mean, you just did a phenomenal job there, Dr.
Thank
Morris.
you, Phil.
Really
Thanks.
impressive. And we're
Thanks
really
so
happy
much.
that we had Viva Learning on board. We had almost 500 people sitting here with you guys taking this class. So it's phenomenal. Great technology back in the back room there. And this Spear Center is just state of the art. So round of applause for our speaker. Thank you very much.
Thank you, everyone. And thanks to Phil. Thanks for making this, simulcast to everyone. That's great. Thanks so much. Okay, thanks now. Break time?